Welcome to the second day of the AI4 2022 Healthcare Summit. In case you missed me yesterday, my name is Patrika Elise, and I'll be your MC for the day. We have an amazing lineup of speakers to learn from today, along with equally notable attendees to network with. If you didn't say hi to that special person yesterday, the time is now. To kick us off today, we have an exciting talk given by Patel titled Locally Developed Machine Learning to Get Mothers in Kenya to Care Faster. Patel is the head of technology at Jacaranda Health, spearheading development and scale up of the organization's technology and data infrastructure across its evidence-based, affordable solutions to serve mothers and their newborns across Kenya. Prior to joining Jacaranda, he worked across operations research and project management roles in local and international banks and private companies. Jay holds a master's degree in computer science from Franklin University in Columbus, Ohio. Please join me in welcoming Jay to the stage.
Good morning, good afternoon, good evening, wherever you are. My name is Jay Patel, Head of Technology at Jacaranda Health. And I'm here to talk about how we use machine learning to help mothers in Kenya get the care they need faster. But first, a little bit of context. Here in Kenya, there are two problems we're trying to solve. On one hand, about 1/3 of maternal deaths in Kenya are due to delays in seeking care. So for example, a mother might not realize she's experiencing a danger sign, and by the time she does and gets to care, the delay has caused complications or worse. On the other hand, once a mother does get to care, just over half of maternal deaths happen due to challenges at the health facilities. And to address that, we have a healthcare provider training and mentorship program. But we're not going to cover that in this presentation. Instead, we're going to go over how we're working to address the first challenge regarding delays in care seeking through our program called Prompts. This is an overview of how Prompts works. And a mother's journey on Prompts starts when she visits one of about 1,000 partner health facilities and signs up for our service. The service is totally free and there's no charge to her at any point, with no exceptions. So once she signs up, the following day, she'll start to receive health information messages, which are customized to how far along in her pregnancy she is. You know, the messages cover things like her health, her pregnancy, and the health of her baby, and cover topics on everything from nutrition to birth preparation, insurance, and especially how to identify danger signs during and after pregnancy. So she'll also get automated reminders about her next facility appointment and the kinds of things to expect during that visit. For example, this should be your second visit. Your healthcare provider should check your blood pressure, discuss nutrition with you, and provide you with an iron supplement. Or maybe this is your baby's 6-week immunization visit, and the following vaccinations are scheduled for that visit. So what happens is that we'll automatically follow up with the mom 2 days after her visit and ask her, how was she treated? Was the blood pressure taken? Did the baby get vaccinations? And if not, why not? Then we'll aggregate and anonymize this data and then feed it back to the counties and facilities so that they have better visibility into what's happening on the ground from their client's perspective, where the service challenges are, and so on. And finally, and this is where the machine learning comes in, moms on the platform can ask us any questions they have about their pregnancy, about their baby, about their health, and we have a help desk that answers these questions. And if the help desk, when they're trying to answer the questions, realize that the mom may be experiencing a danger sign, we'll actually call the mom and refer her to a hospital, and then follow up with her 2 days after the fact to ensure that the situation was resolved and everything is fine. So moms interact with our service primarily through SMS. And it's SMS and not something like WhatsApp or any other app, mostly because a majority of our users still either use feature phones or have data and data cost related concerns. So Real quick, in a small randomized controlled trial that we did, some of the results we've seen, and there's a more extensive RCT underway right now, but some of the results we've seen so far are a 20%, 27% increase in mothers on the platform attending all 4 of their recommended prenatal care checkups as compared with those who are not on PROMs, and a 2x or twice increase in the uptake of postpartum family planning. And 85% of the women that we flagged with a danger sign and referred to a hospital actually were confirmed to have gone and gotten that care. So I'd like to emphasize that this is a two-way service. Again, it's totally free to the mother with machine learning integrated into the Q&A workflow to help triage and answer the questions that we receive. And I'll get into that in just a little bit. So a quick word about our scale to date. We've partnered with about 20 county governments. Counties here in Kenya are the US equivalent of states. We've reached just over 1 million mothers and are enrolling new users at a rate of about 120,000 users per month. And they come from, again, the roughly 1,000 partner health facilities. So the work we do impacts about 60% of deliveries across the country. But we want to ensure that eventually, all women and their families experience childbirth safely and with dignity, and all newborns get a safe start in life. But here's the thing, simply expanding healthcare coverage by itself is really not enough. It is important, and we're focusing also on improving the quality of maternal care in addition to women's access to it. So, a couple of years ago, the help desk was getting about 100 questions a day. They're now getting 4,000 questions a day from moms across the country. And the challenge we're facing not only is how to increase efficiency, but also from the mother's perspective, how to increase relevance for them as the platform grows. The other challenge, when you're getting 4,000 questions per day and growing, as you can see from the chart on the left, how do you find and answer the urgent questions first before moving on to the still important but maybe less urgent questions? So most of the questions are benign, and in fact, one of the most common types of questions are, hey, is it okay if I eat avocados during pregnancy? Can I eat eggs? Can I drink soda? And these types of general questions account for about 95% of the messages that the help desk receives. However, we also get questions about mothers who are experiencing bleeding, for example, or, hey, I have a swelling in my legs and a headache. What's going on? What do I do? When we were answering 100 questions a day, we could just skim through the questions real quick in the order in which they arrived, pick out the ones that needed an urgent answer and fire off those answers before attending to the rest of the questions. But with the volumes we're getting now, it's kind of impossible, which is why we've implemented some natural language processing, or NLP, to help deal with that. And the NLP model we've put together, we call it triage bot. It intercepts and reads all incoming questions first, and then it'll decide what is this mother asking about. So what's the intent behind her question? If, for example, it's the avocado question, that'll be flagged as low priority, assigned the intent of nutrition, and then sent to the help desk's low priority queue. If it's, on the other hand, it's a danger sign about, for example, bleeding, it'll be assigned that intent, given an urgent or high priority, and then sent to the help desk's clinical priority queue. The clinical queue is actually staffed by trained nurses. So what we do is also attach a suggested response to each question, or to each question. When we send this onto the help desk so that they can actually copy paste the response, it's clinically vetted. They can then edit for context and quickly send the answer back to the mom. And here you have, just two examples of intents, nutrition and bleeding, but we have 57 other intents for a total of 59. These are these kinds of questions that you see on the screen are not the only types of messages that moms send us. So we also get messages like, okay, or thanks for your help, or noted, or I'll do as you suggest, in addition to responses to some of the surveys we sent out. So the okay and thanks kinds of questions, along with the survey responses, they actually account for about half of all incoming messages. And these messages, the okay, thanks, and the survey messages, don't need a response most of the time. And so TriageBot has gotten quite good at filtering those out, and so that the help desk also isn't inundated with messages that they don't have to answer. So we've built a TriageBot on top of Google Vertex, which is one of the NLP functions inside of Google Cloud. And we've trained it on the questions that we received from moms. So the first time we did this, we took about 11,000 questions that moms had sent us, and had our team sit down and manually label each one of these questions. So just manually assign an intent to all the questions. 2 years later, we kind of improved on the model by doing the same thing, but on a much larger data set of about 100,000 questions. One thing I'd like to note is that in order to preserve the user's privacy, we don't collect data or train any machine learning models that contains any demographic information. So even today, we don't know our users' names, ID numbers, addresses, age, or anything about their medical history outside of what they share with us and the questions they ask us. We do know the language preference, the facility at which they signed up for the service, how many months pregnant they are, or roughly, when they delivered, and of course their phone number, because that's the channel that we use to communicate with them. It's also good to note that all of this works without having access to demographic or other sensitive data. So a word on language. We noticed that the pattern of new emerging maternal health apps and services is to kind of prioritize English as the dominant language. But we also recognize that information as important as what we're sharing kind of needs to be fully understood and acted on. And we need moms to feel comfortable on the platform, which is why within prompts, moms can ask us questions in both Swahili and English, or a mixture of the two. Even slang, and then they'll receive responses in their preferred language. And the NLP model is able to handle English, Swahili, again, slang, and a mixture of all of the three. However, there is still a little bit of work to do, because while Swahili and English are the dominant languages here in Kenya, they're not necessarily the first, or even maybe in some instances, the second languages for many moms, especially in the peri-urban and rural areas. So we're already working to adapt prompts to cater for local dialects, meaning moms receive information in a way that is immediately accessible, understandable, and able to be acted on in the case of an urgent referral or urgent situation. But it doesn't stop with Kenya, because we're close to launching in Eswatini. We're in early discussions with ministries of health and other local partners in about 3 other countries in East and West Africa. And we can't use the same process for deploying an NLP model in those countries as we did in Kenya, because first, that would mean, collecting questions and messages in the local language for a couple of years before we can even think about training a new, context-specific, country-specific, language-specific NLP model. And so how do we, rapidly deploy the functionality that we've developed here, the lessons we've learned here, and deploy them elsewhere? I honestly don't have the answer to that yet, but we are in the early days of figuring that out. Because in Kenya, what we're doing right now is we run everything through a translator first. So a question comes in from the mom, we run the question through a translator, then the output of the translator goes into the NLP and then onto the help desk. So we trained triage bot on the translated text, and we feed it the translated questions for intent detection. However, for anyone who's used Google Translate or any translator for that matter, sometimes what comes out of it is quite garbled, and more often in the case of Swahili. The NLP model, despite this, does seem to function fairly well. However, our data shows that about half of misidentified intents can actually be traced directly back to bad translation. And so one of our next steps is for us to develop a new model that directly handles Swahili and code mixed text without the need for like a translation or intermediary service, but also develop it in a way that we can apply to non-Kenyan contexts without having to start with large data sets. And this is another barrier that we've run up against with our current tech. And basically that the technology that underlies the NLP model that we're using is kind of opaque, right? So we've built the model on top of Google Vertex, which I think was also, or maybe is still AutoML. And honestly, it's worked really good for us. However, with Vertex, we don't have much in the way of levers we can pull or knobs we can turn to kind of fine tune the behavior of the model. The other thing is that I'm assuming that Vertex has actually been built to cover the broadest possible range of use cases. Our use case, on the other hand, is like super narrow. It's maternal and newborn health related questions in Swahili and English from pregnant women and new mothers in Kenya. And so as a kind of a next step, we're working with Professor Amulya Yadav under the Google AI for Social Good grant to develop a custom NLP model that's actually specifically built with our requirements in mind. And that includes expansion to other languages and contexts. So where does the human factor lie in all of this? How can we increase the help desk's efficiency and maybe see if we can even automatically answer some of these questions that we get from moms? As a first step, I was personally dead set against simply creating like a chatbot because I found that chatbots can be somewhat unpredictable. And as an organization, we're not really comfortable with full automation in the context of responding to moms with some of the topics that we're dealing with, because a wrong answer has the potential for possibly severe consequences. So we just started testing automated responses in a kind of a limited context. And that's been going on for about a little over 6 months now. And so how does it work? Whenever the NLP model detects an intent, it'll also provide a confidence level for that detection. So for example, if a mom's asking about a question about having heartburn, for example, triage bot will say, yeah, this seems to be a question about heartburn, and I'm maybe 68% confident in that evaluation, or 91 or 85% or whatever. So we decided on a threshold, and we found that the 80% threshold worked well for us. And we designed triage bot basically to automatically send an answer to the mother based on the detected intent, but only when the confidence level for that particular intent was over that threshold, in our case, 80%. And the answer is always a standard clinically vetted response, which is written by our staff, OBGYN, or the doctor we have on staff. So let's take an example. Mom says, hey, my head hurts. It's been hurting for a few hours now. What could be the problem? Triage bot thinks that it's maybe 85 or 90% confident that it got the correct intent, and that the intent was detected as headache. It will automatically and instantly send the mom the predefined headache response. It'll be the same standard response for all headache-related questions with no deviation. And then we'll follow that up with a question asking the mom, did the information provided, did that answer your query? The mom can say, yes, it did, or no, it didn't. And if she says yes, that's great. The software will automatically close the ticket in the help desk's interface so that the help desk doesn't have to deal with it, since the mom has indicated she got the information she needed. If the mom says no, or even if she doesn't respond, then the help desk will be notified and they can take a look at the question and send out the answer. In the case of a danger sign, even call the mom. So if an intent detection falls below the 80% threshold, it will just bypass all this automation and go straight to the help desk. After the 6 months, about 85% of moms who've received these instant responses have indicated that their questions have been answered appropriately. And this is taking about, I think, 12% or so, 12, maybe 14% of the help desk's workload, or reducing the help desk's workload by about that much. And we're still in the process of optimizing this further to get that number up. As we grow, we can't just keep adding people to the help desk, and this is one reason we've implemented the automation, is to kind of help with the efficiency and sustainability of the program. So integration of the ML model, along with the instant response stuff and some other efficiencies, have actually helped reduce the response time to danger signs down from, it used to take 24 hours, it takes less than an hour now. But it's important to note that the ML stuff wasn't the only factor in this, right? There were other staffing and like tech-based workflow efficiencies that we've implemented that also helped with the reduction in response time. But the NLP model was a big part of it. So what's next, and where do we go from here? Can we go beyond intent detection and use machine learning to identify other predictors of risk? Maybe. We realized that like 10 types of risks account for 90% of referrals to hospitals. And examples of these include, headaches and fevers and discharge and bleeding and so on. We also have a couple of intents where other questions go. So questions that don't fall into these other specific categories. So we're looking to disaggregate those more general intents and think more proactively about how to engage mothers with, educational messages to quickly identify potential issues. So as an example, a detection of a headache would trigger a message to the mom specifically about how to identify preeclampsia and what kind of action to take in that situation. But do that in a smart way, not just, spam that message out to everyone who sends in a headache question. A couple of other things we're experimenting with include seeing whether, for example, a random forest analysis on questions asked can predict a future danger sign, or even look at historical messaging platforms on a per user basis to algorithmically determine that particular user's risk. And then in the case that we do that, maybe proactively alert the help desk to reach out to a mom based on her messaging history. Does this work require a large budget and deep machine learning expertise? I honestly don't think it does. Because at the core of prompts is RapidPro, and RapidPro is like a digital global good and messaging tool that's supported by UNICEF. It's used around the world. In addition to that, where possible, we use open data systems, databases like Postgres to store and analyze the information. It also gives our government partners like comfort over the long-term sustainability of the platform, and it allows for integration with like other open source tools. What's especially exciting to me is that the lifetime cost per mother on the platform, inclusive of everything I've talked about today, so that the message campaigns, the facility experience surveys, machine learning stuff, the help desk, all of it per user costs less than $1. In fact, it costs like 74 cents per mom for the lifetime of her engagement on the platform. And this, by the way, is running prompts over SMS. And so those costs have also been factored, the SMS costs have also been factored into the 74 cents. if in the future we're able to remove the necessity for translation, maybe increase the accuracy of the NLP models, that'll help drive the costs down even further. And most of what I've talked about today was developed, integrated by the team here in Kenya using open source tools like RapidPro, again, which itself was developed in Rwanda. The Q&A workflow, the NLP model, the help desk stuff, all of that was built and integrated and iterated by the team here in Kenya using a bunch of like off-the-shelf tools like Vertex and Salesforce. Salesforce, by the way, is where the help desk works out of. Most of the custom development that was required was basically in just integrating these various tools in a way that they work seamlessly together. And our guiding principles are that whatever we do, first of all, it has to be effective, because if it isn't, then what's the point of doing it? Number two, it has to be simple. We're a small team. None of us are machine learning engineers. And, we have to integrate, manage, maintain, and iterate everything ourselves. And complexity, of course, comes with maintenance costs, switching costs, and so on. And thirdly, what we do has to be cheap, simply so that we can reach and help more mothers for the same dollar. So most of what I've talked about today is, using either open source or low-cost tools, especially off-the-shelf tools, and integrating them together to help moms and babies across the country. And while our machine learning performance may not yet be good enough for like a research paper, it's actually quite good and practical for real-world applications and real-world triaging. And in fact, the way I know it's effective is that if something breaks and it stops working in that workflow, I will immediately get a call from the help desk asking what's going on and why isn't it working, since the help desk actually has come to rely on it quite a lot. For our work in Kenya and beyond, it's critical that we keep the local context in mind, use local languages and local data wherever possible. And lastly, human oversight is critical to everything we do. And I personally don't want machines talking directly to our moms without having that layer of human oversight, especially because of the kind of topics we deal with and the potential consequences of being or sending out incorrect information. Thank you for listening. I'm happy to answer any questions, and please send us an email if you'd like more information.
Wow, what a great talk. Thank you. I hope you all enjoyed it. Please make your way to your next session. Also, don't forget to check out the networking, accept your connection request, and explore the AI exhibits. Have a great time.